Okay, I'm going to start. Good evening. Uh, 8 o'clock over there, I guess. So um, it's noon here in the United States where I'm speaking from. And this is the last part of the online sessions before we actually come over and do some training in Mauritius. So I'm going to talk about ventilator basics, and this is just a background or the groundwork for our future talks when we get there. So it's going to be mostly general principles about the use of ventilators and when we use it, why we use it, and how we can best use it without causing too much damage to the babies. And it's a vast topic, so I'm going to mostly focus on the basics, but feel free to ask questions. And again, I won't be able to cover every single thing, but I'm focusing mostly on basics. So without much more, I would get into the talk now. Okay, so the most common reason we use ventilators in the NICU is to treat babies with RDS or respiratory distress syndrome. And I think it's a good case example to see how the ventilator is used. So let's look at a baby that has RDS or surfactant deficiency. So if we try to understand what's actually happening with these babies with RDS, we know that there's surfactant deficiency, and so the alveoli tend to collapse. So in a normal baby with adequate surfactant, at the end of expiration, the alveoli are still open because the surfactant is present, and the surfactant gives lowers the surface tension. So there is very little pressure needed to keep the alveoli open. And then, of course, during inspirations, the alveoli open even more in a normal baby. And so between inspiration and expiration, there's actually the alveoli going in a larger size, a smaller size, but never completely going down to a collapse. So that is what surfactant does. It prevents end expiratory collapse of the alveoli. In a baby with surfactant deficiency, the alveoli tend to collapse during expiration. During inspiration, they may open up, but at the end of expiration, they collapse down because there's no surfactant. And this is, in more physiologic or the technical terms, is called the babies have low functional residual capacity, because the capacity of the lung at the end of expiration is important to keep the lung in a very compliant state. The best example is if you're trying to blow up a balloon. The initial part, when your balloon is very small, when you're starting to inflate, you need to generate a very high pressure to get the balloon to start inflating. But once it's in a state of partial inflation, to inflate it further just needs very little pressure. It's the same thing with the alveoli. The initial pressure needed to inflate it and the subsequent pressure is much less if the alveoli is in a state of inflation when you're starting the breath. So the functional residual capacity of the lung, which what the surfactant offers, is lacking in babies with RDS. And the goal of treating RDS is to preserve functional residual capacity. And what does this have? What does this do when the babies do not have the alveoli open at the end of expiration? What happens is there is what's called a ventilation perfusion mismatch. So in this picture, you can see that in the babies with the normal inflated alveoli in the middle have adequate blood flow. So the alveoli are open, the blood is flowing normally. And so the exchange of oxygen and carbon dioxide is perfectly normal. But in RDS, the alveoli are not inflated, but the blood is flowing normally to the lungs. And so what happens is there is a better perfusion, but less ventilation. So that's a problem. It can happen the other way around also when the alveoli are overinflated, but there's no blood supply. That can happen sometimes in like babies with meconium aspiration, where the airway is plugged, and so it creates hyperinflation by a ball valve mechanism, but the blood flow to the lungs is not optimal. And so it creates what's called a ventilation perfusion mismatch. So for optimal breathing, you need a normal open alveolus and a normal flow of blood through the alveolus and a normal exchange of oxygen and carbon dioxide. So when there's either a collapsed alveoli with the normal flow or a normal alveoli with a little blood flow, you create what's called a VQ mismatch. So the VQ mismatch is another reason why there's another concept I want you to understand, apart from the functional residual capacity, is when VQ mismatch occurs, there is hypoxia or hypoxemia. There's low oxygen in the blood. So when you do a blood gas, you get low oxygen. So the two principles I wanted to make you understand. First is the functional residual capacity. Second is the ventilation perfusion mismatch. Okay. The ventilation perfusion mismatch also can occur when there is dead space. So normally, if there is a blood flow to the alveolus and alveolus is open, there is normal alveolar ventilation. But say there's no blood flow to that particular area, or the alveolus is overinflated, there is air coming in, but there's no exchange happening, and that's dead space. And that's wasted ventilation. So the air is coming in, but it's not getting exchange of oxygen and carbon dioxide. So that's the third concept I want you to know is dead space. And so these things will determine how you adjust optimal ventilation for babies. So going back to the ventilation perfusion mismatch, whenever you say the baby has hypoxemia or oxygen desaturation, the baby, in a way, you are describing a VQ mismatch, ventilation perfusion. It says perfusion, but the abbreviation for that is Q. So a low VQ or a high VQ can cause hypoxemia, whereas a normal VQ, which is basically all the blood entering the alveoli is getting oxygenated and going out. Whereas when the alveolus is collapsed, the oxygen is not happening at all, or when there's alveolus is overinflated, there's a lot of wasted ventilation. So these things I want you to keep in mind as we go to the next part of the talk. So I already talked about RDS, where there is alveolar collapse because of lack of surfactant, low functional residual capacity, and a VQ mismatch. What happens in case of a pneumothorax? In a pneumothorax, you have, in the cartoon here, you can see the lungs, the heart, the thymus, and the black part is the air. Air collects between the two parts of the pleura, the visceral and the parietal pleura. That's how it looks on the X-ray. And what happens is the collapsed vascular and airway spaces in the pneumothorax lead to increased vascular resistance, hypoxia, and hypercapnia, and then leads to actually a ventilation perfusion mismatch. And that is the reason for hypoxemia in a pneumothorax. The treatment in a pneumothorax with the ventilation is probably going to be a little different from the baby with RDS or meconium aspiration. So we'll talk about that later. And here is a baby with meconium aspiration syndrome. I'm showing in the cartoon on the left, there's the green part is the meconium. So the meconium can get stuck in the airway and can cause a number of different things. So first, it can get stuck in the airway and cause alveolar collapse. So there's VQ mismatch here because the alveolus are collapsed, blood is perfusing normally. Or it can go and deactivate surfactant and cause secondary RDS in a way, and so the alveolus, there's another VQ mismatch. Or in the third instance, it can cause inflammatory changes because of the presence of inflammatory material, and that's where it can actually now cause the vascular activation and can lead to what's called increased pulmonary vascular resistance and lead to pulmonary hypertension. So here in meconium aspiration, you not only have VQ mismatch, you have perfusion problem, not a ventilation problem sometimes, and or a combination of all these things. So the approach to ventilation in a meconium aspiration syndrome may be a little different than in a baby with RDS. So just wanted to give you these general principles. So we'll come back to these at the end to see what will be the optimal way to ventilate these babies. Okay, so next going into a little bit of a cartoon showing again what I just explained earlier in RDS. The alveoli that are completely nicely open, but some alveoli are collapsed. So the alveoli that are nicely open, the red oxygen molecules can get into the blood, and the gray CO2 molecules can come back, and then air exchange can occur. But some alveoli are collapsed, and so you do not have oxygen exchange, and so you have a VQ mismatch. So one of the ways to treat this is to provide positive pressure to open up this alveolus that was collapsed, and also provide some oxygen with that. And so the combination of oxygen and the open alveolar will normalize the VQ mismatch, and then this baby can now oxygenate better, ventilate better, and all we're doing is providing a CPAP or a positive end expiratory pressure. So if you see the pressure is constantly, whatever you set it, 5 or 6 centimeters of water pressure, but that is enough to keep the alveolus open. So what we're doing is basically, since surfactant is not able to do the job of keeping the alveolus open, we are using CPAP as a way to keep the alveolus open and normalize the functional residual capacity and decrease the VQ mismatch and improve ventilation. So that's the basic strategy. We can use a combination of oxygen and CPAP to manage respiratory distress syndrome. But sometimes you cannot just do with positive pressure because the baby's effort of breathing is low, the baby is depressed, and the baby cannot maintain a normal respiratory rate. In this case, now you have to actually actively make the baby breathe by putting an endotracheal tube and putting the baby on a ventilator. And what the ventilator can do that the CPAP cannot do is it can provide PEEP like we did with the CPAP. It can provide oxygen like we did with the CPAP, but it can now drive air into the lungs using positive inspiratory pressure. And then also you can determine how much the baby is going to inhale, how much the baby is going to exhale by adjusting the inspiratory time. And based on the inspiratory time and expiratory time, you can actually set what the rate the baby is going to breathe at. And then, of course, based on the pressures that you create, the positive end expiratory pressure, the PEEP, and the PIP, the peak inspiratory pressure, and the difference between the two, which is the delta pressure, you can drive air from outside into the lungs. And the way the delta pressure works is by moving air in and out of the lungs, and that is called tidal volume. The tidal volume is the amount of air that moves in or out of the lungs during one breath. So that's what the ventilator is doing that CPAP cannot do, is it is providing you with a number of things extra, which is positive inspiratory pressure, inspiratory and expiratory times, respiratory rate, delta pressure, tidal volume. And all these will do the same thing, correct? Open up the alveolus and correct the VQ mismatch. And also, in this case, help with ventilation, which is blowing off the CO2. The one thing we need to remember with mechanical ventilation is the inspiration part is active from the ventilator, but the expiratory part is the baby's own. The baby has to exhale passively. There's no active exhalation. The ventilator does not suck out the air from the lungs. It just lets the baby breathe out. So you have to keep that in mind. Am I clear so far, and are you able to hear me well?
Yes.
Okay, great, thanks. Okay, so next going into the specifics of the different parts of mechanical ventilation. So let's say if you start the baby on a ventilator, and you have to do a particular, start with some settings. And the basic settings would be the PEEP and the peak inspiratory pressure, and the difference between the peak inspiratory pressure and the PEEP, which is the delta pressure. So I know you use the Leone ventilator, and I'm not sure how it is in that, whether you set the PEEP and the PIP, or you set the PEEP and the pressure above the PIP. Because the PIP is the total pressure from 0 to whatever it is, and the delta pressure is the difference between the total pressure and the PEEP. So whichever way you set it, you have to set a PEEP and expiratory pressure and a inspiratory pressure, peak inspiratory pressure. Also, you need to set inspiratory time, because the pressure has to go in for a particular period of time. So say this baby's cycling on the breath. So there's a pause here, then the inspiration starts, and the baby's inspiration goes, the peak inspiratory pressure is reached after a few minutes. And then based on the inspiratory time, the inspiration is held at that pressure for a period of time. So that's the inspiratory phase. And the expiratory phase starts as soon as the inspiration ends. There is a passive exhalation from the baby. And then the exhalation goes on for a little while, and then the next inspiration starts. So this is called a respiratory cycle, and it consists of inspiratory time and expiratory time. So usually you set the inspiratory time at 0.4 seconds. And so automatically the expiratory time is 1.6 seconds if you're setting a rate of 30. If you're setting a rate of 60, the expiratory time would be half of that. Basically, so 0.4 and 0.6 will be the expiratory time, and so the respiratory cycle would be 1 second. So for a 2-second respiratory cycle, you give 30 breaths a minute. For a 1-second respiratory cycle, you will give 60 breaths a minute. For a 4-second respiratory cycle, you'll give 15 breaths a minute. So that is, so basically it is the respiratory cycle divided by 60 gives you the breath per minute. So this is some of the stuff that you set on the mechanical ventilator. Now, how does this work? Which of these things determine what in terms of the baby's ability to breathe? So let's look at it. So this is like a typical picture from a ventilator, where you have the PEEP, and then so the PEEP is the white line, and then the inspiration starts, and depending on whether the baby is taking its own breaths or the machine breaths, I won't go into the details right now, but the inspiration starts, and then the inspiration pauses for a period of time, and that is at the peak inspiratory pressure. And then the expiration starts and the delta pressure. Okay, so this is while this is happening on the pressure part, the flow part is that the air is flowing into the lungs during the beginning of inspiration, and even during the continuation of the inspiratory cycle, the air is flowing in. At one point, the air stops flowing, which is the beginning of expiration, and the air flows out passively, and goes on the airflow out all the way until the beginning of the next inspiration. And the volume going in is very similar, following the pressures. Next, I want to give you the concept of the mean air pressure. So based on the PEEP and the PIP and the inspiratory time, the area under the curve between these three things gives you some kind of a value. You can do a calculation of PIP minus PEEP times I time, And with some constant, you can determine what is the average pressure going into the lungs at a particular point of the respiratory cycle during inspiration. And that is called mean airway pressure. So it's the mean of all these values, PEEP, PIP, and I time. And that mean inspiratory pressure is the pressure that's keeping the alveolus inflated through the whole respiratory cycle, inspiration, expiration. And that is the key indicator of how well the baby is going to get oxygenated. Because the more the alveolus is open, the less the VQ mismatch and the better oxygenation. If the mean airway pressure is not optimal, the alveoli are not optimally open, you'll have more VQ mismatch and you'll have less oxygenation. So if you want to say you want to oxygenate a baby well, you need to give an optimal mean airway pressure. Next, we go to the other concept, which is the concept of minute ventilation. So what determines, as I told you earlier, the mean airway pressure determines how much oxygenation the baby is going to get. But what determines the carbon dioxide level in your blood gas? That is determined by what's called minute ventilation. So that is the amount of air that is washed in and out of the lung within a minute. And that, so you will know definitely that respiratory rate is involved in that, because that's how much air in and out. And also, as I told you, the air going in and out in each respiratory cycle is called tidal volume. So the minute ventilation is determined by tidal volume and the respiratory rate. So let's say how does tidal volume come into with the pressures? So the difference between the PIP and the PEEP, the delta pressure, is what drives the tidal volume. So if you want to increase your tidal volume, you increase your delta pressure. And you can do that by either decreasing the PEEP or increasing the PIP. And you can increase the delta pressure that way. And that will increase your tidal volume, and increase tidal volume, or you can increase the rate of the babies on the ventilator. Either one of those will increase the minute ventilation and decrease the amount of CO2. So if there's a hypercarbia, the baby has a high CO2, you can increase the respiratory rate, decrease the dead space if you can, and we can talk about that later, but increase in delta pressure or tidal volume and give more time for expiration. So that is the strategy for managing high CO2 on the ventilator. So as I said earlier, minute ventilation is the product of tidal volume times the respiratory rate. And it's all about minute ventilation. Normal minute ventilation in a baby is 250 to 350 mLs per kilogram per minute. Okay, in terms of liters, 0.25 to 0.35 liters per kilo per minute. And normal newborns breathe about 40 to 60 times a minute. And for a baby, the normal tidal volume is about 4 to 6 mLs per breath. So if you calculate that gives you that amount of minute ventilation. So the other thing to remember with tidal volume is that tidal volume is really one of the major things that is involved in lung injury. People used to think that lung injury is determined by high pressures. But what we have come to know is high volume or volume trauma is the one that really causes injury to the lungs. So our goal is to try to give as minimum volume as possible and decrease the volume trauma of the lung. So we need to give optimal volume, but not excessive volume. So that's a key thing to remember. So if you're going to set up a ventilator for a baby, you need to kind of figure out where you're going to start. So you need to know how much tidal volume are you going to give. And as I said, most of the time, it is determined by how much dead space you have. The dead space could be related to the ET tube length, as well as if the lung is hyperinflated and all that. But overall, you need to kind of set something like 4 to 6 mLs per kilo. In a baby with a lot of dead space, for whatever reason, you can go up to 8 mLs per kilo. And the key thing to worry about is volume trauma or hyperinflation of the lungs. Apart from the tidal volume, you need to set up peak inspiratory pressure. Now, the peak inspiratory pressure is the optimal that is just adequate to deliver the amount of volume that you need to deliver, but not too much. And how do you know that? I think the best thing is to kind of listen to the breath sounds and chest rise. And those two things will determine how much peak inspiratory pressure you need to give enough so that lungs are moving, the chest is moving. Six. So that's like six over pressure and pressure declare based on X-rays. That is calculation. Oxygen requirements very high. You can increase the peak to 7 or 8.
Dr. Naveed, sorry to disturb you. There's a noise in the background, I guess. It is breaking. We can't hear you well.
Yes, try a different way. Can you hear me better now?
Yes, now it's better.
Okay. Thanks. All right. I'm going to try this. Are you hearing an echo?
Yes.
Yeah, sorry. Okay. I'm going to try a different way.
Your voice was.
Can you hear me now?
Yes.
Okay. I'm sorry, there's an echo, but I'll speak slowly. Just one second. Okay, what about now? Can you hear me?
Yeah, it's better now.
Can you hear me now?
Yes.
How about now? Can you hear me?
Yes, Doc, we can hear you.
Okay, good. All right. Let me continue. Sorry about the glitch. So I was talking about PEEP and how to adjust PEEP, which is basically a standard 5 to 6 centimeters of water, usually, but in unusual situations when you're needing very high oxygen and the baby is not inflating, you can go up to 7 or 8. Next, about the inspiratory time, that is usually about 4.4 to 0.5 seconds in a newborn, or actually you can go maybe a little less to 0.3, but usually don't go less than 0.3, even in a term baby. And the reason is because of the mechanics of the lung inflation in a baby. And what rate do you start at? It depends on the condition of the baby, but most of the time we start around 30 breaths a minute, and then we adjust up and down based on what the baby's doing. So here is just a synopsis of the initial settings on the ventilator that you would do. Is basically for a newborn that's about 4 kilos or so with normal lungs, you could 6 to 7 mLs of tidal volume, but in a baby with lung disease, about 3 to 5 mLs per kilogram of tidal volume. We usually use 4 to 6 actually in a smaller baby. PIP, which is 18 to 25 centimeters of water to get a good chest rise, and an inspiratory time of 0.3 to 0.4 seconds. So those are the initial controls. And I'm going to go into a little bit into different types of mechanical ventilation, because it's not just the simple IMV, because we have simple IMV is one way, and then there's compulsory mandatory ventilation, and then there's compulsory spontaneous ventilation. There are 3 major modes, of which most of the time in the NICU we use IMV or mandatory breaths with either volume control or pressure control. And I don't know what you use over at in Mauritius in terms of the control, but volume control and pressure control are often confused. But the main thing is that what you're trying to do is to tell the ventilator, is it going to give whatever you're providing based on pressure as the main parameter or volume as the main parameter? And by volume, I mean tidal volume. Most ventilators and most NICUs use pressure control. So basically, they're just the pressures, and that delivers the ventilation to the baby. So the ones that we use most commonly is pressure control SIMV, which is synchronized intermittent mandatory ventilation. That's pressure controlled. And also you provide what's called a pressure support. And the pressure support is provided because of the resistance of the endotracheal tube. You need to actually give a little more pressure when the baby is breathing on its own. When the machine is not breathing and the baby is breathing, you want to support that breath as well. And that is the pressure support. So most common mode of ventilation that we use is pressure control SIMV with pressure support. In some ventilators, and I think maybe Leone is one of them, I'm not sure, it is called by a different name. It is called pressure regulated volume control. So basically it's still pressure regulated, but here you can adjust the tidal volume. So you can say, I want the baby to get only 6 mLs per kilo of tidal volume. And the machine will adjust the pressure to provide that amount of tidal volume. And that's called PRVC, pressure regulated volume control. And that's also a way of providing synchronized IMV, and that can be done with pressure support. So these 2 are the most common modalities of ventilation in the NICUs. There are some NICUs that use what's called the volume control. Basically, there's you do not set the pressures, you set the volume as the initial. And this is very, very rare. I think mostly in the PICU they used volume control. But in the NICUs, mostly it's pressure control. Some NICUs actually would use what's called assist control, which is AC. It is a way of what's called compulsory mandatory ventilation. So basically the machine does all the breaths. It could be synchronized with the babies or not, but the machine breaths are all the breaths. Whereas in IMV, there's machine breaths and the baby can spontaneously breathe on top of it. In the CMV, the continuous mandatory ventilation, there's a modality called assist control. And most NICUs use a pressure control, assist control, or pressure regulated volume control with assist control. So in a nutshell, these are the two modalities that most common NICUs around the world use, which is if you're using CMV or mandatory ventilation, assist control, use either PCAC or PRVCAC. If you're doing a combination of machine and baby breaths, use PCSIMV with pressure support or PRVCSIMV with pressure support. So those are the most common modalities. The other ones are not common. The volume control by itself is not as common, at least from what I know from most places in United States, Europe, and Australia. So there's very rarely the just a compulsory, basically just the CPAP with babies just given pressure support and allowed to breathe normally. We used to do this when you're trying to extubate babies, keep the baby on CPAP on the ventilator, allow the baby to breathe spontaneously with just a little CPAP and pressure support. Most people have stopped doing that because it just increases the work of breathing for the baby and without adding too much benefit. So the five modalities of major modalities of ventilation, I think most places use just two, which is pressure control CMV, the AC assist control module, or the SIMV module with either PRVC or PC. So those are the major modalities, at least that I know of, and we can chat at the end about other things that you may be using. I'm going to just skip this slide and then go into a little bit about volume-induced, ventilator-induced lung injury. And as I told you earlier, the picture on the left shows an electron micrograph of the rupture of the alveoli that occurs with increased volume. The volume overstretches the alveolus and causes rupture, leaking pulmonary fluid and causing damage. And that's the major concern with ventilators. It's called ventilator-induced lung injury, or VALI. And our goal is to decrease volume trauma and prevent overinflation and ventilator-assisted lung injury. So all our strategies in managing the ventilator are in preventing this. And how do you do that? The first thing we do is basically, first, we do not intubate every baby. In fact, even a 24, 25-weeker is given a trial on CPAP and given surfactant by a lesser invasive surfactant administration and then put on CPAP again. And so we try to just not use the ventilator at all, which is the first strategy. The second strategy is even if you're doing the ventilator, try to get the baby off the ventilator as soon as possible. And that is the INSURE method, which is basically intubate, surfactant, extubate. And that is another strategy that most people are using, where you intubate the baby, give surfactant, and extubate right away, and then and the baby breathes on its own. But in a baby that is not breathing spontaneously or is very sick, you do need the ventilator. In that case, you try to use the minimal tidal volume. You can use the minimal rate you can use to get a good amount of oxygen, and even allow permissive hypercapnia, where it allows the CO2 to go into the 50s and 60s and tolerate without having to hyperventilate the baby. But when all this fails, there's another strategy that we have started to use, which decreases the lung injury, is called high frequency oscillation. And from what I gather, some of the NICUs in Mauritius do have high frequency oscillators. So I just want to do a quick introduction to high frequency ventilation and how it compares with what we talked about conventional ventilator. So the figure here shows an overlay of conventional ventilator breaths in the bold and the high frequency ventilator breaths in the light. So I'll come to that, but let's see how high frequency ventilator differs from conventional ventilator. So the way it differs, it does not give tidal volume. There's no tidal volume. There's no air going in and out with the respiratory cycle. In fact, the respiratory cycle is shortened so much that instead of like 30 to 60 breaths a minute, you're breathing about 600 to 800 breaths a minute, which is the high frequency. And if you look at the graph here, which shows the increase and decrease of pressure, so there's a peak and there is a oscillation around the peak. Basically, there's a mean ever pressure, not a peak, sorry. There's a mean airway pressure, and there's oscillation around the mean airway pressure to high or low pressures, and that is what moves the air. So as the oscillation occurs between high and low pressures, what you can see on the left is there's a turbulence created in the airway, and little packets of air keeps getting pushed down with each small breath. And they kind of go into the alveoli by something called the pendulum mechanism. And also, it's basically a complex way of air movement that I think some physicists may describe, but basically the air gets into the alveoli and the CO2 gets out of the alveoli. The other important thing with high frequency ventilator that the expiration is actually active. When the oscillation moves into the negative way, they actually pulls the CO2 out of the lung. So there's an active expiration, unlike in the conventional ventilator. So it's really a great strategy when you're having a high CO2 to get rid of the CO2 because there's an active exhalation. So by various mechanisms, the high frequency provides the oxygen to the baby and gets the CO2 out, and causes very little volume trauma because now the oscillations are very small volumes that are going at a time. So the main differences you would say is the mean airway pressure is used here instead of the PIP, PEEP, or the I time. As I told you, the same concept occurs in conventional ventilation, but we don't call it mean airway pressure. But here we call it mean airway pressure, which is a product of the three. Then the delta pressure is used to drive the air in both situations, but the delta pressure in the high frequency ventilator is very low and it causes very low volume. The tidal volumes are extremely low, but they are of high frequency. And the rate is measured in hertz. So 1 hertz is 60 cycles per minute. So if you use 10 hertz, you're using 600 cycles a minute. So most people use 8 to 10 hertz for the bigger baby and 10 to 12 hertz for the smaller baby. And you can go up to 15 hertz. And paradoxically, the higher the hertz, the less the effective ventilation and less trauma to the baby. So that's why we use the higher hertz for the smaller babies, because the volume trauma is less. But if you want more effective ventilation, you have to decrease the hertz, which is kind of a little paradoxical with the high frequency ventilator, but just have to remember that. That's how the physics works. So that's high frequency ventilator. And now we're talking about just a quick thing about extubation. As I said, our goal is to prevent ventilator-induced lung injury. So try to extubate as soon as possible. And our average time of intubation in our NICU right now, even in a 24, 25-week baby, is about 3 days. Usually it's 24 hours or less. So it's usually given surfactant, wait for the baby to get a little better. Sometimes the effect of the magnesium or the sedation, the baby's not breathing enough. As soon as the baby's breathing enough, there's active weaning and extubation. So there are a number of things that will prevent extubation or cause extubation failure. A baby who's been on a ventilator, the longer the ventilator, the more chances the baby's going to fail. So the earlier extubation actually is better. The baby is not getting used to the ventilator. Use of sedatives and analgesics. The baby's respiratory drive is compromised, so you cannot extubate the babies. Babies who have had airway problems like multiple intubations. Residual lung injury like babies with severe BPD or PIE. And extubation from high frequency or high ventilated settings or high FiO2 is usually not recommended. You want the FiO2 to be about at least 30% or less before you start thinking of extubation. And of course, we've got the other complications like PDA, NEC, and all that, then you would not extubate. But in all other situations, if it's only lung disease or RDS, the aim is to get the baby to surfactant, create good functional residual capacity, decrease VQ mismatch. And as soon as the baby's respiratory drive is good, extubate the baby after giving caffeine. So let's look at a few case scenarios. I've got a little time, but if you say that a baby with RDS with alveolar collapse, what is the best best strategy on the ventilator?
And I would say the best strategy for this baby is not to ventilate the baby, not to put the baby on the ventilator at all, if you can manage that. Because if the baby is spontaneously breathing, all you need to give is surfactant. And most people are now doing surfactant non-invasively by using the LISA technique, the lesser invasive surfactant administration, where you just put a catheter into the lungs, into the trachea, while the baby is spontaneously breathing. You push the surfactant into the lungs, and then take the feeding tube or whatever catheter you put it out, and then the baby's put back on CPAP. Or you can do what's called non-invasive ventilation, where you put the baby on CPAP with some positive inspiratory pressure and eye time. Usually we give a positive inspiratory pressure of about 15 to 20, and an inspiratory time of 0.5 in this situation. And that's non-invasive ventilation. And people are getting away with not intubating babies with just the use of surfactant and non-invasive ventilation and CPAP. But if you do have to intubate the baby for surfactant and baby is very sick, then of course try to get the baby extubated as soon as possible. The principle here is to keep the tidal volume low. So use about 4 to 5, maximum 6 mLs per kilo of tidal volume. Keep the peak inspiratory pressure low, but you can go up on the PEEP if you want. People used to use PEEP of 4 or 5, but now I think people are using PEEP of 5 or 6, and you're going up to 7 or 8 also, depending on the baby's situation. So more use of PEEP, less PIP, less tidal volume, faster extubation. That's the strategy for RDS. What happens in a baby with a pneumothorax? In the baby with pneumothorax, I think the best strategy is not to give tidal volume ventilation, which is the conventional ventilation. The best strategy would be to give high frequency ventilation, where the tidal volume is extremely tiny, there's less volume trauma, and you're not going to increase your air leak. And the high frequency is the best strategy for this, either pneumothorax or pulmonary interstitial emphysema, any of the air leak syndromes, it would be the high frequency ventilator. The most complex issue occurs with meconium aspiration syndrome, especially the baby with PPHN, or pulmonary hypertension of the newborn. As I told you, the number of mechanisms that are active in a baby with meconium aspiration, it's the plugging of the airway causing atelectasis, partial plugging causing overinflation and pneumothorax, surfactant deactivation, inflammation, and the pulmonary vascular resistance going up. So for all these reasons, babies with meconium aspiration syndrome may need a high amount of mean airway pressure to keep the lungs open. But if you do a lot of mean airway pressure, you risk air leaks. So most people have gone to using high frequency ventilator in this situation. But the key thing to remember is that if you're doing high frequency ventilator, you still have to have an optimal inflation of the lungs, the optimal functional residual capacity. And the best way to do that is to do the high frequency, check an X-ray, and make sure that the lungs are inflated at least to 8.5 ribs. If that's the case, then you're doing optimal inflation of the lung, and then hopefully you can get by with that. Sometimes you may need surfactant because of surfactant deficiency, so you have to give surfactant to these babies, and also it helps to clear the meconium a little better. But the third part of this is the pulmonary hypertension part. And with the high frequency ventilator, you can go up on the pressure quite a bit and not have to worry about volume trauma. And most people use high frequency ventilator with a good amount of oxygen and quickly move to nitric oxide if you're not able to ventilate properly because of the VQ mismatch due to pulmonary hypertension, where the blood flow to the lung is compromised and you have a VQ mismatch and the babies get deoxygenated very easily. So for these reasons, high frequency ventilator and the combination with nitric oxide is probably the best strategy for baby with pulmonary meconium aspiration and pulmonary hypertension. So I want to stop there because I know there's a lot to do with this, and hopefully when we come, we will have more time for actual case studies and discussion. But if there are any questions, I would take them now. And I'll unmute everybody, and then maybe you can start asking questions, or you can chat in the questions. There's a, I don't know if it's a question, how to decrease dead space. That's a question that I see chatted in. So the dead space, sometimes it is, you have to be aware of this. Sometimes you're not aware and there's dead space. A good example is a baby that comes from the newborn nursery because of tachypnea, and you put the baby on CPAP. And the baby's still tachypnic, you increase the CPAP. You go from CPAP of 7 to 8 to 9, or 7 to 8. And you see that the baby's still tachypnic and the CO2 is still high of about like 70 to 80, but the baby's oxygenation is improved. So the CPAP did help to improve the oxygenation. So you're now in 21% oxygen, but the baby is still tachypnic and the CO2 is still high. If you take an X-ray on that baby, you will see that the lungs are hyperinflated. And that is because there's too much dead space. The CPAP is creating dead space in the air spaces and causing the problem. So in that case, what you would do is basically take the baby off CPAP or decrease the CPAP. So CPAP could be a contributor to dead space. Another example is a baby with bronchopulmonary dysplasia who's being ventilated. There's a lot of dead space in that because the airways are inflated because of chronic ventilation. And in those babies, actually, you have to counteract the dead space because the dead space will not allow ventilation. So you have to increase your tidal volume in those babies to about 8 to 9 mLs per kilo to get adequate ventilation. And so those are the two areas where I think dead space becomes an issue. How to prevent CPAP bellies in babies on non-invasive ventilation? I think that is the big million-dollar question that nobody has a good answer to. So first of all, again, it's the peak inspiratory pressure that is responsible mostly for the CPAP belly, not the actual CPAP itself, but on non-invasive ventilation, the PIP is the one that drives the air into the stent. So one is to kind of keep the PIP to the minimum that you need to oxygenate the baby or ventilate the baby. The second is we use a combination of venting tubes. So we basically have a feeding tube and then a baby and a thicker bore NG tube to vent or basically kind of decompress the stomach. And those are the strategies that we use, but I don't know if there's any good strategy that's universal. I think it is individual baby based. But that's certainly a problem. CPAP belly is a problem. And we do not have a good answer for that. Any other question? How do you ventilate a baby with congenital diaphragmatic hernia? So as I told you, meconium aspiration itself is quite a challenging situation because there's so many mechanisms acting. Congenital diaphragmatic hernia is even worse. But the primary problem with congenital diaphragmatic hernia, unlike most of the lung disease, is that you have a huge amount of VQ mismatch because one lung is basically not active and so is not providing any oxygenation, even though there's perfusion to the lung. So basically a huge VQ mismatch with the perfusion being there, but no ventilation to that lung. On top of that, you have the presence of intestines in the thoracic cavity and the shift of the mediastinum, the cardiac compromise because of that. So it needs to be attacked on the multiple fronts. But I think most people have used high frequency ventilator as the basic strategy in these babies. So they start with high frequency ventilator so that you do not actually, again, the tidal volume going in and out of the lungs, especially, as that may be a problem. So high frequency ventilator is one strategy. And then trying to maintain the baby in a good cardiovascular equilibrium, because these babies also have significant cardiac compromise, cardiac functional compromise, as well as there could be right or left ventricular failure, all that stuff. So you need to have a good sense of the cardiac function of these babies. Along with the ventilation, you need to support the cardiac. And depending on whether it's right or left-sided failure, you may need to use the proper pressor agent. Also these babies need a good amount of sedation to keep them from getting into worse pulmonary hypertension. And then, of course, nitric oxide would be the way. But the primary mode of ventilation for most babies on with congenital diaphragmatic hernia in our situation is high frequency ventilator. Next question is about who would you advise to put a chest drain in a pneumothorax patient dehydrating before intubating or after? Okay, that's a good question, but I think the primary problem needs to be addressed first. So in a baby with a pneumothorax, the primary problem is the presence of air in the pleural space. It's not that the baby is not able to breathe. The baby can breathe, but the air is compromising the breathing. So I think the first thing to do is to get the air out. And then if the baby is still not able to adequately breathe, because once you get the air out, some babies may be able to breathe effectively. So I think that would be the primary thing. Get the air out first, and then put the baby on the ventilator if you need to. You can support the baby's breathing while you're putting the chest tube. In fact, you may not even need to put the chest tube. You can put in a Gelco or just a needle aspiration to get the tension out, the tension pneumothorax out, and then work on other things. Now, if it is not a tension pneumothorax, if it's just a minor pneumothorax, again, the issue is you need to know what will happen if the air comes out. Will the baby be better? So in those situations, also, I would say I would get the air out first if you think there's enough air to get out. That nowadays we are doing less and less chest tubes. So for a small amount of pneumothorax, we don't even put a chest tube. So it depends on how the baby's function is. If you can get by with supporting the baby on CPAP or whatever to get the baby adequately ventilated, non-oxygenated, even with a pneumothorax, you want to do that. And if it's not, then you would get the air out. And then if still the baby is not well, then intubate. Next question is, would you extubate a post-op patients after laparotomy or NEC onto non-invasive mode, or wait for the patient to ready to extubate and stable? In this case, I would say that you may have to wait until the baby is spontaneously breathing, because the non-invasive ventilation is good, but it's not good for as a sole mechanism for breathing. If the baby is doing part of the breathing, the non-invasive ventilation works. But if the baby is heavily sedated, post-op, has got abdominal issues, that the baby's diaphragm is not working very well, that's a baby that needs to be intubated and mechanically ventilated rather than a non-invasive ventilation. Whether orogastric tube of a baby on CPAP should be closed or open after feeding. We usually keep it open. If you're going to vent the baby, that's what we mean by venting. So it's vented up, and so we keep it open. So the feeding is done immediately after feeding. I think for about 20-30 minutes it's closed, and then it's opened up, and then it's left open for the other 2.5 hours or so before the next feed. But I will check with my nurses and see, because they have all these strategies to do this, and I'm not as familiar with it. But that's a good question, and I will check with the nurses to give you a better answer later on. Any other questions? You can either unmute or you can chat in, and or you can, even after the session is over, you can text on the WhatsApp group, and we'll try to sort out the. Now, I have a question for the audience actually, because I want to make sure that we have we do the optimal kind of training. So you have the Leone ventilator, from what I gather. What kind of modes do you use for that ventilator normally? Would you use SIMV with pressure support, or PRVC with pressure support? Do you use assist control? Do you use volume guarantee? Do you use volume control? Do you use high frequency ventilator? I just want to know. So it says SIPPV, which is synchronized IPPV, which we call SIMV. So that's what we use, and you use as well. What about pressure support? Do you use pressure support on that? So you use SIPPV with volume guarantee, from what I gather. Okay, what about pressure support? Yeah, use pressure support as well. Do you use assist control? ACVG, assist control volume guarantee. Just to refresh, let me just pull up the. From these modalities, do you use anything or similar? What about high frequency ventilator? Do you have that high frequency ventilator? Is it part of that Leone machine or something different? So it's part of the Leone. And do you use high frequency oscillator or a jet? Oscillator. Okay, so that's good. Just chat us the questions that you want us to address when we are there, because again, ventilator is such a huge topic, and we have 3 hours per session that we are going to be there for each hospital. So to optimally use the time, please let us know what specific issues that you want to address, us to address when we are there. And if there are any other questions, that's great. Otherwise, I'm going to stop the recording and close the meeting. Prone position for ventilation. That's a question that was chatted in just now. And the prone position part is, I think, dependent on the baby's status. With most babies with umbilical lines, we don't put the prone position. But if the baby does not have umbilical lines, or, actually, we would like the prone position in certain cases, because some babies ventilate better on the prone position. But again, umbilical lines usually prevent us from doing it. But I think the best option is actually to alternate prone and supine, because that way the dependent part of the lung gets more kind of waterlogged, and there's more VQ mismatch in that area. So if you can rotate the baby prone and supine, that actually is more beneficial, that all the parts of the lungs get adequate inflation. And we put the babies on sides too, yes, depending again on, sometimes you have a right upper lobe atelectasis, you put the baby on the left side to get the right side draining. But sometimes just for comfort and ease and whatever they're doing, we do kind of change the position. But after the first 24 hours, usually, because first 24 hours, I think people are worried about intraventricular hemorrhage with positioning changes. So you have to be careful with that. So prone supine probably, again, depends on the lines, side to side and all that depends on how old the baby is and how long the baby's been on the ventilator. But a baby who's been on more than 2-3 days on the ventilator, I think definitely needs to be moved around so that you do not get atelectasis in one area and hyperinflation in another area. All right, anything else? Okay. Okay, there's one more question. While babies on CPAP, are the interfaces changed? Yes. So CPAP by itself can be delivered a number of different ways. So we have the prongs, we have the masks, and there are different kinds of prongs and masks as well. And then people used some other agents like barriers to make the seal better. So in a particular baby, especially with the breakdown of the nares, I think we use masks more. But we usually start with prongs. We use the Hudson prongs in one unit that I work, and Inca prongs in another unit that I work. And I don't know what you have over there, but I think the prongs, work very well. Especially, we start CPAP in the delivery room. We do not intubate babies at all, as much as possible. So the baby comes out, initial resuscitation, and then CPAP right away. Even if it gives surfactant, we give surfactant and then put the baby on CPAP right away. So the prongs are usually the starting point in the delivery room, where we put the prongs, move the baby to the NICU. And then as the baby gets older, based on the pressure and all that, we change to masks and other kind of CPAPs. Suction should be done only when required and not regularly. Yes, I agree, because suctioning has a lot of adverse effects on the baby. So previously we used to suction them routinely every 4 to 6 hours, and now we suction them as needed. And the less you invade the endotracheal tube, better, because first of all, as you're suctioning, you de-recruit the lung. Again, your functional residual capacity goes down. You're suctioning, so you're causing kind of vagal responses, secretions, a lot of issues related to suctioning. And I don't know, again, whether you use closed suctioning or open suctioning. We have closed suctioning, so the baby's never exposed to the catheter is never exposed to the outside air or bacteria. It's all closed in the system. How long would you advise suctioning before blood gas is done? We usually do, again, suctioning is PRN as needed, and not routinely before every blood gas. We do not, and if we do suction, then we wait at least an hour before getting a blood gas. Because suctioning is not to, it's as needed basis. So there's a problem and there's secretions you have suctioned, then you want to wait a little bit until the baby re-equilibrates to the normal situation. All right, I think we will take the rest of the questions as you on WhatsApp or when we're there. But yeah, give us a list of major problems that you want us to address when we're there, and we will do that. All right, thanks everybody. And the recorded part of this talk would be available maybe in a few hours, and the post test will be put on the site maybe in a few hours also. So we'll take it from there. Thank you.